Thank you very much to Professor Mottrie, Dr. Khurshid Guru, and Dr. James Peabody. All the three presentations are now open for questions and comments, please.
This is Dr. Vivek Bindal from Sargangaram Hospital. My questions goes for regarding the training of people who are already practicing laparoscopic surgery. How many days of training do you think it is essential for a person who is already doing laparoscopic surgery in order to start doing robotic surgery with all the precautions and everything, like with all the safety? So how many days? Is it a short-term kind of thing?
Okay. So your question is for somebody who's already practicing laparoscopic surgery, how many days of training does he need to switch over to robotic surgery? Alex, you want to take that question?
I'm not so sure that an expert in laparoscopic surgery will learn quicker robotic surgery than an expert in open surgery, because actually robotic surgery is laparoscopy, but it has nothing to do with the laparoscopic maneuvering of it. So I know people that I trained who have never ever done one single laparoscopic procedure, and who did much better and who were much quicker in learning than excellent laparoscopic surgeons. So I think you must know about the procedures very well, and I think it's an advantage to know the basic skills of laparoscopy, to learn how to put the trocars, how to deal with adhesions and so on, but I'm not so convinced that to be an expert in laparoscopic surgery is an advantage to learn robotic surgery.
Hello. As a matter of fact, the only common thing between laparoscopic and robotic is that both are using trocars and both are using an endovision system. In laparoscopy, the movements are mirror image, whereas here the movements are intuitive. As you move on the master console, same kind of movement will occur on the instruments, which is actually the opposite. In laparoscopy, if you want to move the tip to left, you have to move the handle to right. So, but his question, okay, then would be, if it's an open surgeon, then how many days of surgery? Because his question was related to number of days of training before you can move to robotic.
So that's very difficult to say and very inter-individual. But I believe that, you want to say something, Jim?
I was just going to agree with what you were saying. I think it really depends on the individual. You can spend a number of days, I think, getting comfortable with working on the console, understanding the clutching and positioning features. That can also be done using a simulator, but that's not a 1 or 2 day experience for most people. Some people it may be, but again, like driving a car, you get better the more you do it, and I think you should really be very comfortable working with the robot before you start working with the robot on a patient. That's the first thing. I think it's very useful to have laparoscopic experience to understand how the anatomy looks laparoscopically, which is different than what you see. I mean, it's the same anatomy, but it looks different laparoscopically. So to be familiar with that, I think, is important. But you do lose the haptic feedback. There's sort of a visual haptic feedback that you develop, which I think is useful, but it takes some time to kind of make that transition. And it may be harder for someone who's used to doing laparoscopy. So in terms of an actual number, I don't think it's possible to say if you do 6 days, you'll be okay. You may be fine in 6 days. You may take 40 days, in 30 cases before you're comfortable. It really depends on the person. Khurshid, do you have any?
I think I echo what Alex and Dr. Peabody said, and I think it all depends on what you want out of it and how you are going to feel safe as a surgeon on the console.
Since being a laparoscopic surgeon for almost 15 years and being a laparoscopic trainer for 10 years, I really like the way I got my training in Roswell Park, because I think they did a huge research and planned the program in such a way that first day they gave us some lectures and gave us some kind of a trial run in the robot. And we are finding it a bit difficult to do it. Then with the ROS simulator training, they had a couple of days of run with us and some clinical exposure to observe stuff. And we came back on the 4th day back on the robot. We found it much more useful and much more easier, and the transition was so good that by end of a week, we got very well experienced in trying to handle the robo, and a week later I came back to India and did India's first robotic bariatrics. So that is excellent way of teaching across. So I also definitely will go with what Khurshid does as a bit of a training and simulator, and going back to robo helps in a very, very big way. Having said that, being a laparoscopic trainer for the last 10 years, I strongly believe it's easier for a lab surgeon to become a robotic surgeon, basically because half the will is already been, half the areas, basically the ergonomics and the principles of port placement, which is very, very important in robotics. Basically because if you do a small error in port placement in laparoscopy, we can push our ports much lateral to any other angle and try to adjust the ergonomics. Whereas in robotics, it purely works around a fulcrum. If you put the ports in a very wrong way, then it's getting it more difficult, and then slight modification of port placement, then laparoscopic ergonomics is a must in robotics, which they taught us very well, and that is where they can cross the well faster, a laparoscopic surgeon. Having said that, one of my colleagues who got trained, again, completely an open surgeon, in a couple of weeks he could do an nephrectomy robotically, never had a laparoscopic experience. So I think, of course, robotics is here to stay, and it cuts short a minimal invasive learning curve very much. But of course, we laparoscopic surgeons can have a bit of a head start than open surgeons. But
Okay,
having said
Dr.
that,
Rajkumar, can you, if
we
you
have
could
to-
kindly be brief, so that we can take
having
other
said that, we
comments.
have to unlearn certain skills definitely from laparoscopy.
Thank you, thank you. His question is, if you train n number of
Yeah.
people,
Yes.
what percentage of them actually will not come up to the level of your expectation?
Okay. Yes, so I believe this is the same question with open surgery, with laparoscopic surgery, and with robotic surgery. There are always, unfortunately, some people that you may train one and show 100 times again the same thing, and that they are really not, let's say, don't have the dexterity to do it. And this happens, and fortunately it is quite rare to see that, because the people that come to get trained are already biased and have already undergone some filters, let's say, before they come to you. So
Is there a selection process that you say that so
yes,
and so is?
this is something which we are working on very, very intensively for the moment. So we want to try to have a way to come to a standardification of credentialing somebody. So we don't know yet exactly what it should comprise, but time of doing something, a procedure is important, like in simulators, that we can measure the improvement of somebody during his learning curve.
Abilities, learning abilities and then executing.
Yes, both.
Yeah. I think going forward too, simulation will probably help weed some people out. If you can have them work on the simulator and they're just not making any progress, then they'll be directed elsewhere.
Can I ask you-
I want to just make one more comment. I think it's a very critical point in which it's very well, very good question. And I think Alex answered it very well. And I want to just add one more comment. If you saw one of my slides where you saw the trainees at a student level and a resident level, what is going to happen is that all this filtration is going to, in the end, happen at a medical school level. What Alex, me, or all of us who have trained robotics, or when we trained, we only get to meet the people who have already crossed that barrier and are now good surgeons at every level that they're looking for a new venue to get into. But it is going to happen at a much lower level, where student will go through this at a third year or a fourth year level and decide that they don't have the aptitude to be a robotic surgeon.
Yeah, I'm Dr. Khanna, gynae surgeon from Apollo, Delhi. I just want to ask one question. Is this simulator available in India and anywhere for the training? Just one. Is it available for training anywhere in India?
Well, I don't think there is a availability in India. I think the Vedaguri Foundation is looking to have one installed here. I think there are negotiations going on to happen.
I think Dr. Bhandari may be in a better position to answer this question.
Absolutely. Yeah.
I'm convinced that simulator is the way to really pave surgeons, give confidence. And first one we are having is with the SI system in the Medanta. And I think most of the SIs would have a simulator, because the number of surgeons we need to train are very large, and it's not possible to send them everybody. So we are having a training center in Chennai very soon, by February or so, in partnership with Ethicon, and there we would be putting a simulator. And we are talking to Dr. Guru, but we are still thinking, how do we involve? Because it's not the simulator. We are looking for the whole lot of cognitive cycle. And not only that, we are looking for how do we advance? Because here the question is, the panel debated a lot, but my question is, here we are talking of a subject who is already a well-experienced laparoscopic or an open surgeon. We are talking of a transition. We are not talking of a resident or a fellow. Yeah, we are talking about it, but in Indian market, the biggest issue is a surgeon who has done 1,500 esophagus wants to move over. His cognitive cycle will have to be very different. So, simulator would be a very big issue.
That's one limitation of simulators, because the program is critical, where you need to go to a place where they can tailor your training to meet what you're looking for, rather than just go sit on a machine and do 10 exercises. They need to tailor what you're looking for, what your weakness is, mid-level evaluation, then go back and help you with the weaknesses you have.
I'm Nitin Rao from Bangalore. I have one question to Dr. Guru. And this is the picture that I saw on the ROS simulator, comparing with the lab simulator. How is it so much better in the ROS simulator? Whereas the lab simulator is like a Nintendo or a PlayStation.
Well, lab simulator is a totally different concept versus a robotic simulator. Robotic simulators are mainly focused to simulate robotic surgery versus laparoscopic simulators, which just do laparoscopic surgery. So where at least the laparoscopic simulators I have seen, majority of them are just focused on kind of a tactile feedback, some of them have, and kind of like box trainer style training. Robotic simulation is totally different. You like Dr. Peabody and Dr. Mottrie mentioned that you're talking about operating with literally only visual cues, no haptic or no other sense of, to train or help you. You're just converting visual cues into real-time surgery. So it's a totally different field. I don't think you can compare apples to oranges here.
No, what I meant was the picture in the ROS simulator is really very good.
Well, that's what I was mentioning. It is real-time operative field. It is not simulation. That is the host technology which you are seeing. You're absolutely right. It's a real surgical scenario, not simulation.
I think
Professor Dasgupta, I think.
The first to say is, Khurshid, I agree that the students are already beginning to self-select. And I slightly disagree with Alex here. There is a paper which is coming out in the BMJ, open from our group. It clearly shows that the V2 is the best platform which can distinguish in a quasi-randomized fashion the students who are going to be good robotic surgeons. No question, that has happened. The second bit is the experienced surgeon's cognition and error will not happen with the technical skills. It will more frequently happen with the non-technical skills. And therefore, I think we need to look a bit beyond just simulating the operation. We can build an igloo around the surgeon. We can build a simulated environment where that surgeon faces a difficulty or a bleeding scenario, how he reacts with the rest of the team, something that's called distributed simulation. So I think in India, it won't just be about the technical training of surgeons, because they're already experienced, as Dr. Bhandari says.
Thank you. I think we should take the last question. There's one gentleman.
Yeah, Dr. Bhandari.
My question is a very short question. Do you especially require any training for the OR staff? And secondly, anything special is to be done for the OR system? Means do you require more spacious OR?
So any modifications in the OR, one, and training for the OR staff?
Yeah, training for the OR staff is mandatory, and they should especially learn how the robot system works, how you have to dock it, how you have to encounter technical problems and so on. And of course, in the OR, you have to see that you have the place to place it, that you know that you have also the screens there and so on. So that is a very brief answer.
Thank you. And can you cut down the cost by piling up a few cases in a particular day? If you do one case per day or one case in a week, and if you do 3 cases on the same day, can you cut down the cost? Is there any effect?
The variable cost stays the same. That means that you have your instruments that you have to renew after every procedure. So I don't think it does make it.
The assembling of the robo, will it cost more?
No, I think, no, it doesn't. And other issue you have to remember is that you operating 3 cases on the console and with your learning curve fatigue is very risky for the patient. That is number one. Number two, there is no cost difference. As Alex said, the cost of the variables is the same even if you do 3 cases in a week or in 1 day.
Okay, thank you.
Thank you. Okay, with that we come to the end of this session, and we'd like to thank Professor Alex Mottrie, Dr. Khurshid Guru, as well as Dr. James Peabody for excellent presentations and the audience for a very interactive discussion. Thank you so much.